So good evening, everyone. So as we can see, the left-hand corner, there is a dinner plate with the gentleman eating with fork and knife. So it is our dinner table. And the right-hand lower corner is our operating laparoscopic team performing laparoscopic surgery. So dinner table to operation table, everything runs by ergonomic principle, all about angles, how we do it, and it makes our life easier. So today my topic is the ergonomics in laparoscopy, how we are implying all this principle to laparoscopy to make our life easier and more efficient. We all know the laparoscopy is beneficial for our patients, reducing pain, less postoperative pain, less postoperative stay, and less morbidity. But in general, laparoscopy imposes quite a bit of musculoskeletal injuries to laparoscopic surgeon. So what should we do? So this is all about ergonomics. It's a scientific study of people at work in terms of equipment design, workplace, layout, the working environment, safety. Basically, it applies and based on the anatomy, physiology, psychology, and engineering, and combined in a systematic approach. This term was formally coined in 1949. So why is this important? Because it reduces the fatigue and improves the task performance. The correct ergonomics reduces the suturing time. So the pressure related to the chronic pain among surgeons relieved by the use of ergonomically designed products. So now there are quite a few studies which is conducted previously. They quoted it was 12 to 18% physical strain was there. However, more recent survey quoted at the rate of 87%, which is quite high. Among these, the neck and backache is the most predominant. So this is how it goes. So why do gynecologists experience musculoskeletal symptoms when they operate laparoscopically? So the first most important thing is posture. So how does posture impact? So now, open surgery, there is a bent neck, back, and twisted torso. But in laparoscopy, it's more of a static posture. It's straight with a twisted neck and straight back. Moreover, during laparoscopic surgery, the upper limb is often held in excessive abduction in order to handle the long instruments. So during open surgery, there's some amount of mobility. We can actually move. But in laparoscopically, definitely we can move. But in general, when I was getting trained, I often noticed earlier days of my training, while I was used to hold camera, often I used to forget move my limbs. So at the end of the 2-hour surgery, I used to get severe knee pain. So that's how the ergonomics come into the place, because since the position of the surgeon and assistants are fixed, studies have shown the impact on surgeons' longevity and ability to operate over a long period of time increases the musculoskeletal symptoms. And almost a lot of participants choose to ignore the such symptoms the Parquet et al. Has seen in their studies. So the first one, let's start from the below, like footwear. We generally do not give importance to the footwear, but it does have an importance. The placement of a gel mat under the surgeon's feet resulted not only in less musculoskeletal pain in the back, knees, and feet during surgery, but also less fatigue and fewer errors. Now, AGE has a lot of studies have been conducted over it. Generally, what they say, a rising rate of backache of it's 60% below the age of 40 years to 80% between 40 to 60 years of age. So there is increased likelihood of shoulder pain was related to the number of years working as a surgeon. So a lot of studies have conducted. Some showed musculoskeletal symptoms were more prevalent in surgeons with less experience. Some showed such symptoms were experienced at an early age. Now, they have conducted observational studies where they have shown that laparoscopic procedures have become mainstream nowadays in a lot of part of the India or internationally, definitely. More and more trainees are performing laparoscopy, while the older generations are still performing more open techniques, because of which there is adaptation of ergonomic principles are less in their way of surgery. Maybe that could be a reason for this musculoskeletal damage in the surgeons and assistants. Now, workload definitely has a high volume of cases, and he or she is likely to suffer more symptoms. Now, the duration of surgery and stress. Now, operating time is inevitably increased compared with the equivalent open procedures, but it definitely decreases with the practice, skill, and experience. Generally, the surgical fatigue syndrome is more than 4 hours long surgery. It happens. Now, what happens in laparoscopy? There is a general lack of three-dimensional vision. There's a fulcrum effect of the long instruments, only 4 degrees of freedom of movement, like up, down, left, right, diminished tactile feedback. So all these leads to decreased efficiency, in fact, affects the efficiency of the surgeon. So let's see OR setup, ideally what it looks like. As we can see, there are ceiling mounted carts enabling easy, versatile positioning of the monitors relative to the operating team with no trailing cables on the floor. It gives a very clean view, and a very clean OR gives you a very soothing effect mentally, which is very important. So the integrated OR system comprises of a systematic trolley in which the laparoscopic equipment, room, camera lights, gas insufflation unit, diathermy, multiple flat screen monitors is permanently installed in ceiling mounted columns. So gender, they have a mixed study. Backache more common in males. If they have seen, female laparoscopic surgeons are more likely to experience musculoskeletal disorders. Let's go to the optimization of the environment. Now, operating table height is very important because, the working surface height relative to that of subject performing manual work determines the upper extremity effort and potential for musculoskeletal injury. The most operating tables can be lowered at the best to a height of 725 millimeter. So the instrument position at the elbow height of the surgeon actually shows you the lowest task difficulty. Improving efficiency of the surgeon. See, the elbow of the surgeon is at the level of the handle of the instrument. This is the perfect way of handling the instrument, and the height of the table is quite lowered down. Now, height adjustment. Sometimes the table cannot be lowered down. Sometimes the surgeon is quite a short in height. Doesn't matter. We do have a flat foot platform, so we can make that can make our life easier. But the design and size must consider the balance, particularly when using foot diathermy and controls. Now, the position of the operating table. This is our classical position of the operating table, is Lloyd-Davis position. What are these? This is nothing but the Trendelenburg position with legs apart or head down lithotomy. So what the definition is supine position of the body with hips flexed at 15 degrees as the basic angle and 30-degree head down tilt. So this is how it looks like, Lloyd-Davis position, head down, 30-degree, and hips flexed, 15-degree. So it is nothing but a combination of lithotomy position and Trendelenburg position. Now, in lithotomy, as we can appreciate, there is a different hip flexion angle. It's generally done in vaginal surgeries. Now, optimal operating table. So this is how one should design the operation table. There should be double pelvic cut, angled padded leg rest. That is what is called OR direct stirrups or Allen stirrup, or at least lithotomy padded rods, which can be angled at 45 degree. We can see there's a padded shoulder rest so that the patient doesn't skid once the table head end is lowered down, and preferably it is motorized. So this is how our operating table should look like. Now here in this picture, we can see the position of the arm. This is the preferable position of the arm of the patient, stuck to the side of the body, wrapped up properly, because sometimes it's been seen that some or the patient's arms are quite highly abducted by the side of the ears. That should not be done because that sometimes they create a brachial plexus injury. So draping may have some pockets for keeping instruments, tangle-free wires, proper positioning of the wires, gas tubing, light cable, camera wires actually avoids tangle, gives you a visual pleasure. Now this is the surgical team. Again, we can see the picture. The surgeon and the first assistant at the head end who is holding the camera There's second assistant, the right side, who is assisting with the instruments. They actually all are viewing the monitor placed at the foot end, straight. Now the theatre nurse, who is standing between the legs of the patient, they view the ceiling mounted monitor that is also exactly straight at the head of the table. So there are two trolleys, one trolley for vaginal instrument kept at the leg end, one trolley with laparoscopic instrument at surgeon side. Now this is one of the laparoscopy unit of Apollo. As we can see, 3 surgeons. This is how we have said that at the end of the TLH. So the theatre nurse has moved down to assistant number 4. Now the height of the monitor. The task performance is best when the screen is placed directly in front of the surgeon, in line with his or her forearm motor axis. The task time also significantly shorter with monitor directly in front. Now, Van Det et al., they have conducted all these studies. So they suggested these guidelines of position, height, and distance of the monitor. So what it is exactly? The picture shows, the first picture A, the monitor directly in front with the angle alpha between viewing direction. So maximum walking direction should be less than the 15 degree. Now, the B, the demonstrating the viewing angle for the surgeon, it should be below the eye level. So again, we're depicting the picture B. The ideal height for the middle of the monitor should be 5 to 9 degree below the horizontal plane of the eye, or 20 centimeter below the height of the surgeon. Now the distance of the monitor should preferably be 80 centimeter to 120 centimeter. That actually avoids excessive accommodation. Walking too close actually leads to quite a bit of eye strain. Again, going for, as the monitor size increases, so does the maximum view distance up to a certain limit. So there is a dictum. They say that 3 to 9 times the diagonal distance of the monitor screen should be the monitor distance. So the minimum view distance is 90 centimeter, irrespective of the monitor size. So these are the instruments. Now pistol handled instruments, what they cause a radial deviation. So they increases the digital nerve and neuropathy. The eggshell type of needle holders, they give you ulnar deviation. So they also give the neuropathy. The instruments, laparoscopic instruments require 3 to 5 times the muscle contraction force of open instruments. So handles are unfortunately available in one size. So sometimes if they have seen the gloves numbers less than whoever is using less than 6.5 gloves, they are having difficulty and more hand strain while operating with these kinds of instruments. So let's come to the port placement. So this is very important when we are doing port placement. This is the ergonomic principle. So manipulation angle, elevation angle, baseball diamond concept, and triangulation. So this is manipulation angle. So what is that? This is the angle between the instruments, active and assisting. That should not be more than or less than 45 to 60 degrees. And this increases your task efficiency. Now, azimuth angle, there's another angle called azimuth. This is the angle between the instrument and optical axis of the endoscope. So what they say manipulation angle should be 45 to 75 degree with equal azimuth angles, but 90 degree creates the greatest muscle workload. The elevation angle, the angle between the instrument and the horizontal plane, that is operating table. So there's a direct correlation. Manipulation and elevation angles should be equal, that is 60 degree, and that combination carries the shortest execution time. Now, fulcrum effect, it's very important. Sometimes we have seen it. Like if the port is very close to the target organ of dissection, elevation angle will rise. It will be 90 degree. So surgery can't be performed. Instrument will not lift the tissue. Okay. Now, if the port is very far from the target dissection, the elevation angle will be less, like 10 degrees. So handle of the instruments will almost touch the body of the patient. So in that case also we'll encounter a lot of difficulty. Now, this is a main concept, the baseball concept or triangulation. So there is no uniform consensus about the port placement. Now, the smooth instrument manipulation, trocars are placed in triangular fashion, which is called baseball diamond coat concept. It reduces the soaring between instruments. So what is exactly it is? Now, if we see this picture, now this is the thumb where it meets, it's the optics. That means our primary trocar or say umbilical port. Now, where this index finger meets, it's the target organ. And now this is the anatomical snuff box. What they say is tip of the index finger over the target of dissection, put the tip of the thumb over the site of telescope. Position of anatomical snuff box will give you rough estimation where the secondary port can be done in adults on both sides. Like here and here. It's almost like an arc. Some people say it's like a triangle. So sometimes Dr. Rajendra Pal Sangpal says the angle of bliss. So this is the triangle he speaks about. If we put our secondary trocars over this snuff box, it creates perfectly ergonomically sound port placement.
Sorry to interrupt, ma'am. 10 minutes remains.
Yeah. So the target organs 15 to 20 centimeter from center port. 2 remaining trocars placed in same 15 to 20 centimeter arc at 5 to 7 centimeter on either side of the trocar. Now this allows the instruments to walk at 60-degree angle with target tissue. Now this avoids the problem of long handle due to too far or too near placement of ports and the problems of abdominal wall interference. Now coming to the port placement arrangements. Now this is the basic. Like for example, some surgeons prefer contralateral port. What does it mean? Primary port, that is umbilical trocar in the center, and both the ports, one in the left side, one in the right side. So this is called contralateral. Ipsilateral means the 2 secondary ports will be on the same side. Majorly the surgeons perform left-sided true trocars and right-sided one assistant trocar. Now there's a midline also. Like for example, there are 2 trocars on contralaterally and 3rd trocar in the midline suprapubic area, which is called midline. Each one of them, they have their own advantages and disadvantages. So every surgeon have their own preferences because of their long-term practice and their everyday surgery. Now let's see the first one. This is the midline where we have 3rd trocar in the suprapubic area. Now, when we are having a suprapubic area and 2 iliac fossas, 2 secondary trocars, the right hand usually, in the dominant hand, usually they operate through the suprapubic area. The advantages is the surgeon can operate on both the sides without any deviation or too much of a lateral because the suprapubic port is center. You can dissect both the sides, but the disadvantage is your right hand is quite abducted. So it is really strenuous for shoulder pain. Initially, when I was getting trained, we trained like this. So after doing quite a few of surgery, I found I'm unable to carry out suprapubic port because this was giving a shoulder pain. But there are quite a few surgeons who prefers to do this in this kind of a surgery. Now, the ipsilateral one, here we can say that the primary port in the umbilicus, 2 secondary trocars in the left side, A and B, they should be, as we already discussed, baseball concept. Now here what happens when we're doing suturing, we are very when we're doing surgery also, we are very comfortable because we can hold our arms almost by the side of our body. So it's quite ergonomically easy to do that. But what they say is when we're suturing, the 2 instruments go almost parallel. They're not.
Tanuka, you're not audible. I think we have lost.
There's some internet issue.
Tanuka, we can't hear you.
Tanuka,
no, we can't hear you. I'm not sure it's coming from your end, but we can't hear you.
Yeah, back.
You're muted now. Can you unmute yourself?
Is it okay, sir?
Yeah, it's okay now.
No, very good. Carry on, please.
Yeah. So, so the ipsilateral port has advantage of but the disadvantage is while doing suturing, the instruments go really parallel, so the tying knot may be a little bit of difficult. So let's do the take-home message. That is, ergonomically sound operating system, we should invest and we should plan so that we decrease the operating time, increase surgical efficiency, and we should train our assistants. So how to stand when somebody is holding camera, somebody who's assisting, how to do the port ergonomically so that the journey of surgery becomes smooth, and that's it. And the patient position should be optimum. We should careful about the monitoring viewing angle, because if you're standing for a long time, so they actually increases the cervical spondylitis and neck issues, which we can pretty avoid. Now, knowledge about the principles of port placement. When we are starting off the laparoscopy, we should know this particular thing, this knowledge, and we should apply it when we are doing the surgery. And sometimes some people say the laparoscopic surgeon must do a physical fitness program. As I know, I used to work with Dr. Dashma Patra sir. So he still goes late at night home. He still does his strength training with dumbbells. So I'm sure the physical fitness program can help us in the long run. And special attention of manufacturers of instruments towards ergonomics so that it becomes user-friendly, surgeon-friendly. So practice doesn't make you perfect. It's the only perfect practice makes us perfect. So ergonomics is everywhere, whether we are flipping omelette, we're stirring tea, or whether we are doing surgery. So thank you so much for having me here. Since gratitude is the right attitude, I thank all of you for having me. Thank you, Arnav sir.